All right, our 3 minutes is up. Bernardo, please get us started.
Okay. Hello, everybody. Welcome to the second day of the presentations of the MPH thesis. We're so happy to have you here. So far, we have 18 participants and getting more and more by the minute. Before we start, we would like to welcome you and give some general information about the logistics for this session. Nura, we can see the slide. Thank you. Thanks so much. We have scheduled for today 9 presentations with 1 hour break at 10:40 and return at 11:40. So pretty much the logistics will be that we give 10 minutes for each one of the presenters and 5 minutes for questions and answers. Nura will be kindly reminding everybody as they approach the deadline with a 2-minute warning, as in a football game. She's very nice, but she's very strict, so better stick to the 10 minutes. And then she will help us to coordinate the questions. You can submit them in the chat box, or also, I guess, Nura, raising your hand with this feature in Zoom. So Nura can give you the word. We would ask all of us to stay muted, and it's up to each one of us if you want to keep your video on or on according to your preference. As you receive a message right now, the presentations are being recorded. So if there is any concern about it, please let us know. But most important, enjoy this session. It's a very nice session that we really like it. We had a great session yesterday, and it's like a nice chance to see all the work that you have been doing over the master's program, and especially in this final stretch of the thesis, that it's a very key component of this learning experience. So I don't know if there is any additional comments. Steve, Julie, Sarah, if you would like to add anything else, or Nura, any housekeeping that I am skipping?
No, that's perfect. So as Bernardo said, please enter your questions in the chat box, and I will get to it as soon as we're done. And if there's still time, I would be happy to take questions aloud. So just let me know.
Great. So with no more introductions, we leave the ground for Katie Welgan, I guess. If Katie, if you want to share your screen, and we can start with your presentation.
Yeah, I don't think my committee is here yet. Should I wait until 9:25 to see if they trickle in, or go ahead and get started now?
You're on mute.
Sorry. So we can wait. We're a little bit ahead of schedule, so we can wait another 3 minutes. But if you know when if you see your committee, just let us know and we can turn our videos back on. So we can wait, definitely.
Okay, sounds good.
Or Bernardo, do you think something else?
No, I think that's fine. I think we are good in terms of time. And
okay.
I guess in the invitation, I think and even in the agenda, this is scheduled for 9:25. So
yeah,
we can take a couple of minutes, no problem.
Okay. Great.
Okay, I'll get my screen set up while we wait, and then
perfect. Yes.
Wait until 9:25.
Okay, great. All right, Katie, you ready to go?
Yeah, I still don't see them, but I'm happy to get started.
Okay, sorry about that.
Yeah, no worries. All right, so my thesis is on quantifying racial and ethnic disparities in US COVID-19 vaccine access and acceptance. And my committee is made up of Em and Bobby. So the motivation behind this study comes from the really well-documented mortality disparities by race, ethnicity in the US in terms of COVID-19 mortality. Many different groups have documented these disparities. On the right, I show a plot that comes out of our work at IHME, looking at the elevated risk of mortality relative to the non-Hispanic white group in every age group in Hispanic or Latino and non-Hispanic Black or African American groups. And while there are many interventions that are needed to address the structural racism that has produced these disparities, because we know that COVID-19 vaccines are so effective in preventing mortality, ensuring equitable access to vaccines is one key step in reducing these drastic mortality disparities that we've observed so far in the pandemic. There is some previous evidence on vaccine access and acceptance by race and ethnicity in the US. The CDC collects vaccination data by race and ethnicity that suggests that minority racial and ethnic groups are underrepresented in the vaccinated population, despite their overrepresentation in COVID-19 case and death statistics. But race ethnicity data is missing for 44% of vaccinated persons in the CDC data, which means that it makes it really difficult for us to quantify the exact extent of these disparities. And it's especially difficult to quantify disparities when we're looking at smaller racial or ethnic groups or when we're attempting to disaggregate by state. There's also some survey data from earlier in the pandemic when vaccines were first becoming available that confirmed higher rates of vaccine hesitancy among racial and ethnic minority groups. But many of these surveys were quite small, and so they were only powered to consider larger racial or ethnic groups, such as the non-Hispanic white group, non-Hispanic Black group, and Hispanic or Latino groups, and were also not powered to disaggregate by state. And because vaccine allocation policy and the creation of vaccine tiers often occurs at the state level, it's particularly important for this type of research to have information on disparities by state. So this project attempts to kind of counteract some of the limitations of this existing data by providing a more comprehensive look at disparities in vaccine access and acceptance by race, ethnicity, and state. So I had three specific research aims. The first was to quantify disparities in vaccine access by race, ethnicity, and state. The second was to do the same with disparities in vaccine acceptance. And the third was to identify differences in specific reasons that people gave for vaccine hesitancy, again, by race, ethnicity, and by state. The data source that this analysis is based on is the results of the US COVID-19 symptom survey from Carnegie Mellon University. This is a relatively large survey of adult Facebook users. It has over 50,000 daily respondents. It's been running daily since April of 2020 and has had vaccine questions since January of 2021. And the data that I present here is up to date through the last day of April of this year. Although this is a survey only of adult Facebook users, the researchers also have calculated survey weights that correct for both non-response error and coverage error. So the results that I present here will be weighted estimates, which means that as long as these weights are valid, they should be representative of the adult US population as opposed to only representative of the adult population of Facebook users in the United States. I also wanted to be specific about the way that race and ethnicity is measured in the survey and will be defined in the rest of my presentation. So participants are asked to self-report race and ethnicity in two separate questions and are allowed to select multiple race categories in the race question. For this analysis, I've collapsed race and ethnicity into the race ethnicity categories that you see on the screen. And importantly, for privacy reasons, data is suppressed when there are fewer than 100 respondents in a given demographic category. So you'll see in the slides that follow that I'm often missing data for racial or ethnic groups that have a particularly small population in a given state. This means that the non-Hispanic, Native Hawaiian, and Pacific Islander results are limited to only 3 states. And I'm also not able to present results for the non-Hispanic, other, or multiracial group at all, given the lack of respondents in that category in almost all states.
5 minutes.
Thanks. All right, so the first indicator that I looked at was vaccine access by race and ethnicity. So this plot shows the proportion of individuals in each state who have already received at least one COVID-19 vaccine dose. And these are relative rates relative to the rate of vaccination in the non-Hispanic white group in each state. So groups that are green in this plot have a rate of vaccination access that is higher than the non-Hispanic white group in that state, and states that are purple have a relatively lower rate of vaccination. So you can see from this plot that the Hispanic or Latino group, non-Hispanic American Indian or Alaska Native group, and the non-Hispanic Black or African American group often have a lower relative rate of vaccine access, while the non-Hispanic Asian group generally has a greater relative rate of access. But there are pretty substantial variations in the extent and direction of these disparities by geography. In particular, if you take a look at the southern region of the United States for the non-Hispanic Black or African American group, you can see that in many of these states, this group actually has a relatively larger rate of vaccination. Given that a lot of states prioritize vaccine access in terms of risk of mortality for variables like age or occupation, I also wanted to visualize rates of vaccine access relative to COVID-19 mortality risk by race ethnicity. So these values are again relative to either the rate of mortality or vaccination in each state, with red points representing the relative rate of mortality with the non-Hispanic white group as the reference group, and blue points representing the relative rate of vaccination, again relative to the non-Hispanic white group. And each facet represents a race or ethnicity for which we have enough data to produce this plot in at least 4 states. And as you can see, for every race ethnicity group shown here, in the majority of states, these populations have a lower rate of vaccination relative to the non-Hispanic white group and a higher relative rate of mortality. Although again, the extent of these disparities varies pretty substantially by geography. I also think it's particularly interesting to take a look at the non-Hispanic American Indian or Alaska Native plot, because this population was relatively successfully prioritized in many states with large reservations populations to receive earlier access to the vaccine. For example, in Montana, any individual who identified as a Native American or American Indian was able to receive access to the vaccine in January or February if they wanted to. And you can see from this plot that that group actually did experience a greater rate of vaccination relative to the non-Hispanic white population in that state. But you can also see that that elevation in vaccination rate pales compared to the elevation in mortality rate that that group experienced. So to me, this plot really shows that vaccination is only one piece of the package of interventions that will be necessary to reduce mortality disparities overall.
2 minutes.
Thanks. So the second indicator that I looked at was vaccine acceptance by race and ethnicity. These values, again, are relative rates of vaccine acceptance relative to the non-Hispanic white group, with green states indicating a greater rate of acceptance and purple states indicating a lower rate of acceptance relative to that reference group. And in contrast to the access plot, where the Hispanic or Latino group, non-Hispanic American Indian or Alaska Native group, and non-Hispanic Black or African American group had lower rates of vaccine access relative to the reference, here we see that in many states, these racial ethnic groups actually have a greater rate of vaccine acceptance. And this really goes against some of the evidence that we saw at the very beginning of the pandemic when these surveys first started coming out, which suggested that many of these groups had a lower rate of vaccine acceptance. Instead, we see, particularly in the American South, again, that these groups have a higher rate of vaccine acceptance relative to the non-Hispanic white group at this point in the pandemic. I also wanted to take a look at gains in vaccine acceptance over time. So this is again relative change between January and April of this year, and a darker green indicates a greater relative change. And you can see that in most states, the non-Hispanic Black or African American group experienced greater gains relative to other race ethnicity groups in this time period. And to me, this is really a testament to a lot of the organizing that we've heard about in this particular community through churches and other community organizations. And this data affirms that this organizing was actually effective, perhaps in increasing vaccine acceptance in this community. The final indicator that I looked at was vaccine hesitancy and the reasons for vaccine hesitancy. So on the y-axis, I've shown the different reasons for hesitancy that people were asked about in the survey, and on the x-axis, I've shown the different states. And each cell is colored by the race ethnicity group that was most likely to express a reason for hesitancy within a given state. So the first takeaway that I have from this plot is that there's an extreme level of variation in reasons for hesitancy across geographies and across race ethnicity groups, but there are also a few geographic trends that I think come out from this data. At the top of this plot, I've listed reasons for hesitancy that are most related to broader mistrust of institutions or distrust of the medical institution or vaccines in general, such as not trusting the government or not trusting the vaccine. And you see that many of these reasons in many states are most common among the non-Hispanic white group. At the bottom of the plot, I've listed reasons that are more related to specific concerns about safety of the COVID-19 vaccine in particular, such as having a health condition that impacts safety or wanting to wait and see if the vaccine is safe. And in many states, we see that these reasons are most common among the non-Hispanic Black or African American group or the Hispanic or Latino group. And this is really against some of the evidence, again, that we saw from survey data at the beginning of the pandemic, which suggested that distrust of institutions or broader distrust of the medical institution in general would be the underlying reason for hesitancy in communities of color. Instead, at this point in April, we see that these reasons are actually more common in the non-Hispanic white group, whereas non-Hispanic Black or African American individuals and Latino individuals in many states are actually more likely to have specific concerns about the safety of this vaccine in particular. So in conclusion, in many states, racial and ethnic minority communities are less likely to have access to the COVID-19 vaccine, but more likely to express acceptance of the vaccine relative to non-Hispanic white communities. And vaccine acceptance has increased most dramatically since January among Hispanic or Latino and non-Hispanic Black communities. Finally, the motivating reasons behind remaining vaccine hesitancy differ substantially by race, ethnicity, and geography, and future work should investigate the barriers to access among the substantial number of unvaccinated individuals who express vaccine acceptance. Thank you.
Great job, Katie. We unfortunately only have time for one question. If anyone wants to ask that big question to Katie, and everything else can go in the chat box for sure, because there was a lot of good content.
I have a question, Nura. Katie, thanks so much. Very interesting work. I mean, now the debate is moving more like from prevention to vaccination. So especially these final results about acceptance and hesitancy to absorb the vaccine, has there been any discussion or any plans to have any discussion with some stakeholders? Because this can really guide the strategies moving forward.
Yeah, I think at IHME, we're still kind of early in our work on racial and ethnic health disparities in general. So that's kind of one of my goals for before I leave, is to set up a way to disseminate some of this work. We also had a lot of work on education disparities by race ethnicity related to COVID, and then Lauren's thesis last year on mortality disparities, which mine is kind of based off of. And so I'm hoping that once this paper goes out in June, we'll also identify some like community level stakeholders that we can work with for that. But so far, I don't really have any concrete plans, but I think it's definitely very important.
There's a question from Steve who says, could you have estimated vaccine acceptance from the CDC versus safe post-vaccine survey.
Called VSafe,
Oh,
one-
Be safe.
Be safe, sorry.
the one that many of us took it after
Yeah.
vaccine.
I can't recall if I took that one as well. I can't recall how race ethnicity data was collected in that survey or if it was, but I am looking for the paper to include a comparison to other data sources. So right now I've just been looking at like how these rates from the Facebook survey compare to rates in state, like Department of Health records that I can find on their website, but that is a fantastic suggestion. I'll have to look into that since that's definitely a very rich source of data.
Great, thank you so much, Katie, for your presentation.
Thanks, Katie. So we would move on to the next presentation that is by Haley Lesinski, also from the Health Metrics and Evaluation track. And thanks so much. We have members of her committee here. Great, welcome.
Great. I'll go ahead and get started. Hello, everyone. My name is Haley Lesinski, and I'm here to talk about my thesis on multiple micronutrient inadequacy. My project has been chaired by Dr. Ashkan Afshin, and Dr. Nick Kasbaum is also on my thesis committee. To provide some background on micronutrients, micronutrients are vitamins and minerals, many of which are necessary for healthy development, disease prevention, and general well-being. Three of the most important micronutrients are modeled in the Global Burden of Disease study and are also the focal point for this presentation: the vitamin A, iron, and zinc deficiency. I have them listed here on the slide, along with some of the clinical manifestations associated with that deficiency. Because of the widespread and adverse effects of micronutrient deficiency, micronutrients have been considered a major public health priority for several decades. When we're talking about micronutrient status, we could be talking about any point along this simple causal diagram. However, generally micronutrient deficiency is determined by the level of a micronutrient that is circulating in your body, or the biological availability. This can be assessed using biomarkers like serum retinol, a common one for vitamin A. However, understanding micronutrient intake levels, the left side of this diagram, or clinical manifestations of deficiency, the right side of this diagram, can help give a fuller picture of micronutrients. So for this project, I'm looking at something slightly different, the root cause of micronutrient deficiency, dietary intake, which we're calling micronutrient inadequacy. So the project overview, the goal is to estimate the number of people globally with inadequate intake of micronutrients. To do this, I'm using a joint distribution approach. I'm employing global burden of disease methods alongside a custom strategy to derive estimates of micronutrient mean intake. And I've also developed machinery that can work for many micronutrients. But as I mentioned, I'm going to be focusing just on vitamin A, zinc, and iron in this project. So this is a diagram of the project and the process that I've implemented. I won't have time to talk about a lot of these boxes, but I wanted to show this to communicate the scope of this work and also to dive into some of the details on the data and the overarching methods. So there's two main sources of data in my project. First, we have availability data that comes from the UN Food and Agricultural Organization database. From this data source, we get a time series of micronutrient availability from 1980 to 2017 at the national level for nearly all countries that I'm interested in. This data source gives us very high data coverage, but is on availability as opposed to intake data. Our second data source represents the intake of micronutrients, which is from dietary recall surveys that report micronutrient intake at the individual level. To get data in this bucket, we undertook a new data review effort and have thus far identified 129 survey years from 27 survey families that provide individual level intake of vitamin A, zinc, or iron. I'll note that out of that 129 survey years, 81% are from high-income countries. We've spent a lot of time trying to get a geographically diverse set of data, but unfortunately are only limited by what is available. So there's two key methods, overarching methods to my project that I think can help communicate exactly what I've done. The first is the distribution approach to calculating prevalence, and the second is the joint distribution. So the first, the distribution prevalence approach, that some of you may be familiar with. If we have a distribution of a particular indicator, so in this case, zinc intake, which we have plotted on the x-axis, and then we have its distribution such that if we were to integrate under this curve, we'd get a value of 1, representing everyone in this population. We can then take a cut point or a threshold that marks inadequate intake, and we can integrate underneath that cut point under the distribution, and that gives us the prevalence of inadequate intake. This is a pretty simple approach to calculating prevalence, but nonetheless, there are a couple requisite pieces of information in order to do this. The first is the distribution shape, whether or not this distribution is normal, log normal, exponential. Secondly, whether or not, or what the population mean is for this population, and also the population standard deviation. The mean and standard deviation tell you how to move the distribution along the x-axis. And then finally, we need knowledge of the cut point or the threshold for inadequacy. I have produced estimates of all 4 of these by location, but unfortunately, I'm only going to have time to talk in some detail about how we derive the population mean estimates.
5 minutes.
Additionally, I'm not just interested in the marginal distributions of vitamin A, iron, and zinc. I'm interested in looking at the joint distribution, so how intakes of vitamin A correlate with zinc and iron. So in order to simulate the joint distribution, I've used copulas, which are an effective way to decompose a joint distribution into its correlation structure and its marginal distributions. So in this use case, the copula is informed by the joint distribution or the correlation structure that is observed in that individual level intake data I was talking about earlier. Then we use the copula to simulate individuals that have that existing correlation structure in their intake, transform it into the marginal distribution space, and then can determine their nutrient adequacy status using the distribution prevalence approach that I discussed earlier. In this table on the right, in this figure on the right, I show how the original individual level data on intakes of the 3 micronutrient, how that correlates with each other in original space, and also once we use the copula, what that looks like once it's modeled. And you can see that it does a very good job at representing that correlation structure. To really drive home the utility of copulas, I focus here on just thinking about vitamin A and zinc, where we have our 2 intake thresholds, and we effectively partition our domain up into 4 different quadrants. So using copulas means that rather than just understanding what proportion of individuals have an adequate intake of zinc and vitamin A, we can actually get 4 different mutually exclusive bins. We can get the proportion of individuals in the red quadrant, which have an adequate intake of zinc and vitamin A, the proportion of the green quadrant, which have an adequate intake of neither, and the blue and purple, which have an adequate intake of just one. When I'm actually doing this for my project and I'm using iron as well, I'll have 8 different mutually exclusive categories. So this joint distribution approach allows me to understand a lot more of what is happening at the micronutrient intake level. Back to my process overview, I just want to say one thing about how I have produced my estimates for mean intake. That is largely by leveraging something called a crosswalk, which is a bias adjustment where data with different definitions are adjusted to a gold standard definition using a network meta-regression. So in this case, I only have one alternative definition, which is the data on micronutrient availability. And then my gold standard definition is micronutrient intake. And so for countries, years, sexes, and age groups, where there's both intake data and availability data, I match those observations, take the ratio of availability to intake, and model it to determine an adjustment factor. This adjustment factor is then used to apply to the availability data to transform it into intake. We do something like this in the global burden of disease for the dietary risk factors estimation process. And so it might be familiar to some of you, but this is definitely one of the key assumptions that has pretty tremendous implications on my results.
2 minutes.
Moving into the result space. This right here is my main result, which shows what the proportion of individuals in each of those 8 mutually exclusive categories that I mentioned earlier is by age and sex. So to highlight a couple of things here, first, we see that there's lower prevalence values for younger individuals than older individuals because of the requirements that vary by age, and there's lower requirements for younger individuals. Secondly, we really can notice this dark red bump in females of childbearing age, which is because the requirement levels for females who are lactating or pregnant are much higher than for females and males who are not. And then finally, when we think about which categories we see the most amount of the population in, it's the light pink, the light green, and the light blue. And those represent zinc only, vitamin A only, and inadequate intake of both vitamin A and zinc, highlighting that these results show much more inadequate intake of zinc and vitamin A than they do of iron. We can look at the same results by superregion, and we can see that there's lower overall prevalence of inadequate intake of any micronutrient in the high income region, and then much higher, close to 100% of the population in the South Asia region. By numbers, we find that 6 billion individuals have inadequate dietary intake for at least one of the 3 micronutrients that I've looked at. 5 billion individuals have inadequate intake of vitamin A, 4.4 of zinc, and only 1.1 of iron. To conclude, I want to mention some limitations. First of all, data coverage is one of the key limitations of this project. We have minimal data on intake in low and middle income countries, which means that the results are really reliant on the availability data and also the intake data that we do have for high income countries. A consequence of having low data coverage is also the fact that our results are very sensitive to that crosswalk adjustment. And if we were to alter the crosswalk adjustment, say have region-specific crosswalk values, we'd see pretty different results. And then also, dietary recall as a type of data has its own limitations. In this case, it's really relevant that there was very high interpersonal variation, meaning that intakes vary day to day for a single individual. And then also dietary intake of micronutrients doesn't capture intake from fortification or supplementation. So what this means is that our estimates of dietary intake are not necessarily capturing true intake. They're going to be a very close approximation. There's a couple of limitations that are important to consider. And so finally, to conclude, through this project, I saw generally lower intake relative to requirements than I expected, which means that a large proportion of the global population is at risk for micronutrient inadequacy. This work highlights a couple of future directions for research. The first is the actual reliability of these intake requirements and whether or not they are too conservative. Secondly, it highlights the need to understand the true intake, which includes micronutrient content coming from fortification and supplementation, which is something that we're really limited by with the data that is currently available. And then finally, and perhaps the most important, is really understanding this relationship between the intake of a micronutrient and the biological availability of that micronutrient. Since our result is that a large proportion of the global population is at risk for micronutrient inadequacy, it would be helpful to understand exactly what that means for the prevalence of micronutrient deficiency and the subsequent clinical manifestations of deficiency. So with that, I would like to give a deep thanks to Ashkan and Nick for being my committee members, and also shout out to Janina, Vinay, and Molly for their contributions to this project. Thank you.
Thanks so much, Haley. Nura, do we have any questions?
No questions at the moment.
Let me start, Haley. I mean, congratulations. This is very sophisticated work, and really it shows the quality of the team that you have been working with. What is like the main contribution? What is the main difference in your approach on nutrient intake and doing this copula analysis as compared to other estimates of macronutrient deficiencies that we could see from other sources?
Yeah, it's a great question. I think the reality is that when we're talking about assessing micronutrient status, it's all focused on deficiency estimates, what proportion of various individuals have inadequate biological availability. But most of the interventions that target micronutrient status occur at that intake level. So trying to supplement, fortify, do something at the intake level. And so I'm not saying that this work is actually producing estimates on micronutrient deficiency, because it's not, it's micronutrient inadequacy. But micronutrient inadequacy is inexplicably, it's very clearly linked to micronutrient deficiency. And so understanding what's happening at this stage, if individuals around the world are actually eating enough of these micronutrients to satisfy requirements, is pretty crucial. And then I would think another Another relevant thing here is this calling into question the thresholds and whether or not the requirement thresholds are actually reliable going forward, since that's what a lot of individuals use to benchmark their nutrient intake.
Any other questions for Haley?
I'll ask a question simply since there's no other question.
Yeah.
I have recently heard that the World Food Program has estimated enormous increases, like hundreds of millions of increased kids malnourished, probably through either weight for age or growth retardation in South Asia alone. I think India alone or South Asia. So we're seeing, and this is recent stuff, in spite of a lot of, people thinking things are getting better. To what extent when you look at micronutrient, and particularly, zinc and iron deficiencies, to what extent are they simply a reflection of the fact that kids aren't getting enough food in this area of gross inequality, increasing inequality?
Yeah, it's a great question. Part of the reason we were looking at this joint distribution approach was trying to understand that. So if we're seeing that most individuals don't have adequate intake of all of the key micronutrients, then it's kind of more of a comment about there just generally being food inadequacy in that particular area. So I think that that's definitely one of the ways that this work can be used to address that question. I think obviously the points you're making are very valid, and it's likely just not having enough food in general and less about one micronutrient versus another micronutrient. Hopefully with, what was that?
Do you think that focusing on the micronutrients takes some of the important focus away from the fact that poor people aren't getting enough food?
I would argue that they can be done at the same time, but I definitely think that highlighting energy content is pretty critical, and like the number of calories. So thinking just about micronutrient intake in a vacuum without how much of the diet is this particular micronutrient, I think that that's a really good point, and it's important to also take energy into consideration.
Okay, great, thanks.
Thank you.
Good job, Haley. Thank you so much.
Thanks, Haley. Then we will move on to the next presentation by Gift Wan on risk factors and antimicrobial resistance profiles of Neisseria gonorrhea.
Good morning, everyone. Can you see my screen?
Yes, please.
Okay. Great. Good morning, everyone, and welcome to my thesis presentation. My name is Gift Wan, and I am in the Global Health MPH program. I'll be talking to you all about my thesis, which is on the risk factors and antimicrobial resistance profile of Neisseria gonorrhea associated with repeat gonococcal infection in patients attending Public Health Seattle and King County Sexual Health Clinic between 2017 and 2020. I worked with Dr. Soge as committee chair, Dr. Graham and Dr. Kareni as committee members. I will walk us through a background, methods, results, limitation, and discussion sections. As a background, gonorrhea is the second most common reportable sexually transmitted disease in the US. In 2019, there were over 600,000 cases of gonorrhea reported in the US. Cases of gonorrhea has been rising over the years and has increased by 92% since 2009 in the US. And this increasing rate nationally is also consistent with what is seen in Washington state, especially in large counties like King and Pierce County. There were over 11,000 cases of gonorrhea in Washington state in 2019. Untreated gonorrhea can lead to ectopic pregnancy and pelvic inflammatory disease in women, infertility in women and men, and increases the transmission of STIs like HIV. Gonorrhea develops resistance to antibiotics very quickly, and antibiotic-resistant gonorrhea is a threat that requires aggressive and urgent action. Over the years, gonorrhea has developed resistance to most of the antibiotics recommended for treatment. This graph shows rising resistance level for antibiotics like ciprofloxacin, which used to be a treatment option for gonorrhea, but is no longer recommended due to rising resistance level. If you look at this graph, you see that ciprofloxacin is at high point as 35% as at 2019. Increasing antibiotic resistance has led to revision of treatment guidelines, the last being in 2020 when the CDC revised the treatment guideline for treatment of gonorrhea. Re-exposure to persons with untreated gonorrhea can lead to new gonorrheal infections and other sexually transmitted infections and diseases like HIV. So for my first aim, I examined risk factors associated with risk with repeat gonococcal infection among participants attending the sexual health clinic. And for my second aim, I compared antimicrobial resistance profile between participants with single gonococcal infection with those who had repeat gonococcal infections. For the purposes of this study, I would like to define some terms. A gonorrhea positive case was determined by the presence of Neisseria gonorrhea, confounded by positive nucleic acid amplification test or positive culture in samples collected from one or more anatomic sites like urethra, cervix, rectum, or pharynx. While a repeat gonococcal infection was defined as persons with 2 or more gonococcal infections occurring more than 14 days apart between February 2017 to December 2020. So for methods, this is a retrospective study nested in the ongoing CDC's response to resistant gonorrhea surveillance project called SURGE. The population are persons seeking care at the Public Health Seattle Sexual Health Clinic located in Harborview between February 2017 and December 2020. For my analysis, I used logistic regression to evaluate the associations between potential risk factors and repeat gonococcal infection for the first aim. And for the second aim, I used t-tests to compare the main difference of resistance to 7 antibiotics for individuals who had repeat gonococcal infection and compared it to individuals with single infections. Now for my results. This table shows some baseline characteristics for single and repeat gonococcal infection. I would like to point out that of the 2,219 unique individuals who we had results for, there were 577 repeat infections determined by a gonorrhea positive nucleic acid amplification or culture test, occurring more than 14 days from an initial gonorrhea positive test, and 1,642 single infection. Going through the table, we see that people identifying as white, Hispanic or Latino and Black have the highest repeat infection of 59, 20, and 16%, and that 96% of men had a repeat infection as compared to about 2% of women and 7% for people identifying as non-binary. This table shows correlates of repeat gonococcal infection. In the univariate model, characteristics such as people who identify as Black had a self-reported history of gonorrhea and prior HIV history were statistically significant risk factors predicting repeat gonococcal infection in the univariate model alone. People who identify as female had a documented reported history of gonorrhea, were currently on pre-exposure prophylaxis, and declared a history of non-injection recreational drug use in the last 12 months, were statistically significant characteristics predicting repeat gonococcal infection in both the univariate and multivariate models. It was also interesting to see that female as a gender of sex partner was a significant factor in both models. This final table shows comparison of antibiotic resistance between single and repeat gonococcal infection. For the second aim, we saw that a mean difference of 9, 5, and 6% for ciprofloxacin, penicillin, and tetracycline for participants who had a repeat gonococcal infection, which were all statistically significant. Ciprofloxacin, penicillin, and tetracycline are no longer recommended drugs for treatment of gonorrhea. And this is what we're seeing on this table is consistent with national resistance data, like the one that I showed earlier, the graph. Resistance was not seen in repeat infections for gentamicin, cefixime, and ceftriaxone. And I would state quickly that ceftriaxone is the drug of choice recommended by CDC for the treatment of gonorrhea. So for my limitation, data was skewed towards men because Public Health Seattle and King County Sexual Health Clinic sees more men than women. Data was only from the Public Health Seattle and King County Clinic, so which means that we potentially miss individuals who were diagnosed for repeat gonococcal infection elsewhere.
2 minutes.
The sexual health clinic was also closed at some point last year due to COVID lockdown, and this may have impacted the number of participants who, this would have affected the number of participants who would seek care for screening. We also did not have genotypic data to confirm gonococcal strain. In conclusion, treatment interventions should target groups at increased risk for repeat gonococcal infections like adolescents and young adults, people who identify as Black, women, and their sex partners. Routine counseling, testing, and screening should be done for participants at high risk for repeat gonococcal infection. It is also important that partner notification, therapy, and referral is encouraged to reduce reinfection by untreated sex partners. I would also state that because gonorrhea develops antibiotic resistance quickly, rising gonorrhea rate has implication on what antibiotic is available for treatment. I want to thank my thesis chair and committee members for their support and guidance, Christina and clinicians at Public Health Seattle and King County Clinic who work with participants, and the Biostat Consulting Group for bouncing analysis ideas with me. Thank you all for listening. I would now take your questions and comments.
Great
Thanks,
job,
Gil.
Gift. Oh, sorry. Great job, Gift. So we've got a question from Saida who says, congrats. What was the maximum number of repeat infections among your participants?
Thanks. That's a great question. So from the data, we saw that participant had a maximum number of 12 repeat infections during the observation period. So we had the highest numbers from 2 and it trickled down to 12. So I think if I remember correctly, we had an individual who had 12 repeat infection. Then I think about 3 individuals who had repeat infection, and it was increasing until 2. So 12 is the maximum number for repeat infection.
Great. Another question from one of your peers. Sorry, so I saw that PrEP use was a significant factor. Oh my God, these are going so fast. Okay, I saw that a PrEP use was a significant factor predicting repeat infection. Do you have a sense why? A sense of why?
So while my study didn't, so this is the slide. While my study didn't look particularly at PrEP, but it discovered that current use of PrEP was significantly a factor predicting repeat infection. I think, and this is just my opinion, it may be that folks who are on PrEP have a reduced sense of risk, and so they feel like being on PrEP reduces their chances of being infected with other sexually transmitted infections. So that kind of increases their risk perception and they engage in risky behavior. But my study didn't venture into that reason, yeah.
Okay, thank you. Question from Donna Deno, who says, great presentation. You may have mentioned this, but what was the time period between tests to define repeat infection as opposed to lingering nucleic acid after treatment? Also, is retesting already part of national guidance for GC?
Thanks, Donna. That's a very interesting question. So from the analysis, we excluded people who had infection between 0 and less than 14 days. So we defined repeat infection as people who had infection in greater than 14 days. So if your preceding infection was less than 14 days, then that will be seen as either treatment failure or as the same infection. And so that was not seen as repeat infection. Then the next question. So I think that part of the guideline is to encourage retesting to help against repeat infection.
Okay, and I'm gonna lump in these two questions, one from Donna, one from Steve, which was a follow-up. Was PrEP adjusted for HIV infection, i.e. is PrEP a marker of HIV infection? That's Donna. Steve says, given that GC in women are often asymptomatic, how do you think your results are relevant for women?
So because from this study, we had more men than women, but we also know that there is the sexual interaction that happens. So part of this result that's on the slide here shows that people who reported female only as a gender of sex partner had an increased risk. And it is my sense that the sexual interaction that folks have, like people have with females, is also something that should be considered. It's at high risk. I don't know if I answered your question, Steve.
Yes, thank you.
Okay, Donna's question, I didn't get that, please. You can repeat.
I just wondered if maybe the PrEP was a marker of HIV infection. And so the risk factor for PrEP, maybe if you looked at that only among those who are HIV infected.
So this was just for PrEP use. It's excluded those who are already on PrEP, who are HIV positive, sorry.
Great, that's all the time we have. Thank you, Gift.
Okay.
Good job.
Thanks so much, Gift. So we would move on to the next presentation by Sophia Emmons, also from the Health Metrics and Evaluation track. Please, Sophia.
Great, thanks everyone, and good morning. The title of my thesis is Drivers of Inpatient Mortality Reduction in Hospitalized COVID-19 Patients. And my thesis committee are Drs. Greg Roth, who's the chair, Catherine Johnson, and then Emmanuel Gaikadu. So to give some motivation for this research, you may all know that IHME has been releasing COVID-19 models and projections since very early in the pandemic, and that this research really started with hospital capacity forecasts. And mortality in hospitalized COVID-19 patients has really remained an important indicator of the progress of the pandemic. And this thesis's research kind of originated from work with the IHME COVID team. So for some context, we saw a really sharp decline in in-hospital mortality from the first few months of the pandemic onwards. And until pretty recently, there were very few groups that examined that decline. Now it's been described in England, which is shown in this figure, New York, Mexico, and most recently by our team last month. And there's a couple of hypotheses for this reduction, which I've put onto the slide. So this thesis asks the following questions. How has inpatient COVID-19 mortality changed over the course of the pandemic? Which demographic, clinical, or hospital level features have contributed to these changes? And then with the hypothesis that hospital level burden is associated with inpatient mortality rates and may explain some of the change in mortality over the first 9 months of the pandemic. So for these questions, I was interested in a data set that had information on a lot of person level and hospital level factors, things like demographics, past medical history like comorbidities, features presenting at admission, which might indicate how sick someone is as they present, and then, hospital level features that might indicate testing in the region and how overwhelmed that hospital may have been by COVID-19 patients at the time. So for this, we worked with the American Heart Association, who have a quality care registry that early in the pandemic was extended to COVID-19 patients. And in this registry, participating hospitals do chart abstractions of all adult hospitalized COVID-19 patients they saw in their sites. And we used this data to run several logistic regression models with an inpatient, like an in-hospital death as the outcome variable. We limited analyses to first hospitalizations when people were readmitted, restricted to those admitted between March and November because of small numbers prior to March, and used multiple imputation to address missingness in our data. And then for all models, we included a random effect on hospital to account for both within and across hospital variation. In total, there were 21,037 patients enrolled in 107 sites from March to November of 2020, and 3,246 died in the hospital, which is about 15.4%. The mean age of these patients is 62 and 46% are female. And on average, these patients were slightly overweight, admitted with slightly suboptimal oxygenation levels, and were slightly hypertensive. Over the 4 time periods that we examined, inpatient death fell from 18.7% in March and April to 10.5% in September through November. And I've highlighted a few places where the demographics changed as well. The average age fell and the proportion of female patients increased. The race ethnicity breakdown of these patients changed, although I'll say that this is not a self-reported variable. These were abstracted from the charts. In addition, the prevalence of pulmonary infiltrates seen on chest x-rays decreased while the use of supplemental oxygen increased. And it's important to remember that these time periods are fairly close together. It's the same disease over the course of 8 or 9 months. And so changes in presentation or severity might be unexpected. To expand on changes in mortality, age has been really well described as a predictor of death, and our analysis supports this. So this figure shows inpatient death on the y-axis and then month of admission on the x-axis, and the colors represent age groups. So these really light colors down at the bottom are younger patients and dark red are older patients. And we can see how both inpatient mortality decreased over time most dramatically between March and June, but also how older patients had higher mortality than younger patients in all time periods that we examined. We ran several logistic regression models with a variety of predictors, and I want to first orient you to how I'll present these results. I've grouped predictors or covariates into bins here on the left, and I've shown the adjusted odds ratios for each of these variables with circles spreading out on the x-axis. And the dotted line over on the left is 1, meaning no impact. So anything you see on the left of the dotted line confers a survival benefit, to the right an increased risk of mortality, where the lines are confidence intervals, 95% confidence intervals. And I've colored in dots where the p-value is less than 0.05. So for this first model, I included time period, age, race, ethnicity, sex, and past medical history. And you can see, first of all, this dramatic relationship between age and mortality, increased survival benefit for female patients, and a lot of past medical history comorbidities relating to increased risk of death. But in addition, that every time period relative to March and April was associated with increased survival. In the second model, we added features known at admission, like blood pressure and heart rate. It gets a little bit small, I apologize. But the reference values here are just normal clinical values, like blood pressure between 110 and 120. We see significance, especially variables that are related to oxygenation levels. So here on the right is pulse ox below 70, and a little bit below it is patients who come in with supplemental oxygen. And first of all, you see that some of these comorbidity variables have lost significance, which is probably expected because of the correlation between them and the features known in admission. But we still see that time period is very significant. So next, we addressed hospital level effects. So first, to estimate the load of a hospital, or how overwhelmed they might have been with COVID-19 patients, we tallied the number of COVID patients admitted in each hospital on a given day and divided by the number of total hospital beds that that hospital had. So this represents the proportion of all hospital beds occupied by COVID-19 patients on a given day. And I've just organized this by region, so you can see the spike in New York in March and April. We also looked at the number of days between COVID-19 diagnosis and hospitalization to approximate testing availability. So in the beginning, you can see that most patients were either diagnosed upon admission or during their hospital stay. And as time went on, more patients were diagnosed before they were admitted. So here are the final model results after adding those hospital level variables. It's small again, but I'll zoom in on the next slide. But I did want to show the entire modeling framework for this final model on the right.
2 minutes.
Thanks. And here are just the time and hospital level features, which were the core questions of my thesis. And they revealed two things. First, even after adjusting for all of the demographic, clinical, and hospital level variables that I've mentioned during this presentation, we still see a very significant time effect where survival in March and April was about 30% lower than all other months. And second, we see that hospital load does not seem to be predictive, but time between diagnosis and hospitalization does. So diagnosing COVID-19 prior to hospitalization, even when adjusting for disease severity, is associated with greater survival. So before conclusions, I did want to say that there's some limitations to this study. This is a retrospective analysis where data was uploaded retroactively by hospitals. So more patients and records exist earlier in the time series than later. And some variables, especially around oxygenation, like including proning, were unavailable. So there may be a great many unmeasured confounders in this data set. We also only looked at features known in admission and didn't look at in-hospital interventions. But in conclusion, inpatient mortality decreased in the sites that we observed between March and November 2020 from 18.7% to 10.5%. And we saw several demographic, clinical, and hospital level features that were significantly associated. However, hospital load was not one of them. And in total, these variables did not fully explain the change in mortality observed in this data set. So further explanations of this time effect might include mortality displacement, non-invasive oxygenation techniques, or any of the number of other unmeasured factors. So I want to say thank you so much, especially to my thesis committee, Greg, Catherine, and Emanuela, and the IHME COVID team, and the American Heart Association as well.
Thanks, Sophia. Nura, do we have any questions?
No questions yet. Oh, actually, Juan Sebastian has his hand up. Juan, if you want to go ahead and ask your question.
Yeah, thank you. Hey, Sophia, thanks for your presentation and congratulations. Really good work. I wanted to know if you are thinking of considering maybe for a next step, including information related to or data related to how clinicians and how the medical personnel is getting more information about COVID. I mean, in terms of how they are more prepared on how to respond to COVID. Also thinking about like the whole year that we have been learning about the disease and whether this could be included as one specific factor, or maybe we need some type of qualitative study, like going to the clinics and asking them how they were changing in their like knowledge about the disease?
Yeah, great question. I think that sort of qualitative data would be really interesting here. It's unfortunately a limitation of this data set that they're only patient level factors associated. So there's some ways that we can kind of approximate that by looking at medications given or interventions given. But with this data set, it's really hard to get at, I think, exactly what your point is, which is that knowledge of COVID-19 and treatment changed a lot over the course of the pandemic, and different sites and geographies learn from each other and learn from other parts of the world. So I think it's still an ongoing question in this work of how exactly to get at that factor. And yeah, different external studies might be a really interesting thing to pull in here.
Thank you.
Great. You have a question from Rachel Nugent, who says, Sophia, did comorbidities play much of a role in in-hospital mortality?
They did, yeah. I can pull up the final model results there. It's a little bit hard to see, but this bucket here is looking at past medical history that patients had upon admission. So when we further account for their vitals and admission features, some of that effect size goes away, but really these are on the same causal pathway. So when unadjusted for those things, you see increased mortality with all of these things except for smoking, and then a measure of cardiovascular function. So I think it's definitely true that that comorbidities and past medical history impact mortality, and goes along with other literature that we've seen as well.
Great. And the last question is from Steve, who has his hand up. Steve, go ahead.
Okay, thanks. That was a great presentation, Sophia. My question is very much like Juan's, which is, in my clinical experience, that improvements in mortality often have to do with just little things that you learn over time. Hospital mortality from myocardial infarction has reduced substantially, and there's not one big thing. And one of the things that struck me about your analysis is that hospital load actually may be sort of a proxy for increased information and knowledge and experience around dealing with these kinds of things. And your response to Juan was great, which is, hey, we don't have that data, so we can't tell. But I wonder, is there a way of comparing the kind of experience and time of experience with COVID to other diseases or other conditions, where we might have data, where something was new, and then over a period of time the mortality goes down, and to sort of understand that, given the fact that your data is going to be limited by these sort of rather subjective pieces of information and knowledge.
Yeah, no, that's a great question and a really interesting thought of how we can use non-COVID related data to kind of get at these questions. I think if anything, these results illustrate your point, which is that many small things, and not necessarily just one thing, like all the COVID patients are older in a particular month, have contributed to mortality. So that's where I see the kind of contribution of this work. But I do think it'd be really interesting to do what both of you are suggesting and look to other sources, other diseases, more qualitative analyses. And on your point about hospital load, I think it's really well taken too. I was surprised to not see significance, but think that there might be many things in that one variable, both how overwhelmed a system might have been, but also the experience that they might have had after seeing COVID patients.
Thank you.
Thank you all.
Great. Thank you so much, Sophia.
Thanks, Sophia. Well, with this, we will move on to the last presentation of this block by Jocelyn Powelson of the General Track. Jocelyn, we hear you.
Let's see, are you all able to see my screen at this point?
Yes, perfect.
Okay, perfect. Well, thank you everyone for zooming in today to hear about my thesis. I'm looking forward to sharing what I've been working on for about 15 months now. For my thesis, I was working with Village Reach, which is one of the smaller global health organizations based here in Seattle. We conducted a qualitative study on determinants of immunization dropout among children under 2 in Mozambique. In this presentation, I'll give a brief overview of the study methods and then focus in on our preliminary findings and discuss next steps. Immunizations are a highly effective and impactful public health intervention and save roughly 2 to 3 million lives each year. However, there's still really significant gaps in vaccination coverage, and globally, an estimated nearly 20 million children don't complete the basic immunization schedule each year, leaving them susceptible to disease and illness. In Zambezia province, Mozambique, where this study was conducted, only about half of children have completed the recommended immunizations for children under age 2. In Gile and Namaroi districts, our study sites, an estimated 20% of children drop out of the under 2 immunization process, which means that they receive some vaccines, but then don't complete the vaccination process, which usually requires about 5 to 6 visits to the health facility. The objective of our study was to understand why some caregivers drop out of their vaccination process before their children are fully immunized. We used a community-based participatory approach, which means that we tried to engage members of the study population throughout the research process. Specifically, we worked with 4 caregiver researchers who were actively engaged in data collection and analysis. We collected data from 12 health workers and from 32 caregivers. To elicit data from the caregivers, we used a method called photo voice, in which we provided caregivers with cameras, asked them to take photos of scenes that related to their vaccination experience, and then the caregiver researchers returned to discuss the photos and conduct semi-structured interviews. For the health workers, we asked them to send photos or messages over SMS anytime they had a notable experience relating to under 2 immunizations. After 3 weeks of message exchanges, the caregiver researchers conducted semi-structured interviews with them as well. As an American woman who's never been to Mozambique, I had to consider my identity while working on this study. I helped to prepare many of the study plans and research tools and also led the analysis process. However, I believe that the participatory approach that we used helped to minimize any biases and ensured that the research and the results were centered around the perspectives and experiences of the participants. We used the increasing vaccination model shown here as a framework for our data collection and analysis. This model was developed by UNICEF, and it's made up of 5 different categories of factors that relate to a caregiver's immunization experience. Within these categories, we can find both facilitators and barriers to vaccination. This model helped us to organize the data and to better understand where barriers arise along this vaccination process. At the bottom of the slide, you can see an overview of the steps that we took in our analysis. After developing a codebook and coding the transcripts, we prepared summaries of findings and representative quotations for each code. We summarized codes separately for health workers and for caregivers of fully vaccinated children and those of partially vaccinated children. The caregiver researchers used these summaries to identify themes during a participatory analysis workshop. We then further developed those themes with additional discussion and input from the caregiver researchers. From this process, we identified 4 main patterns of barriers that interact together to drive vaccination dropouts. The first dropout pattern relates to reduced trust in the health system. Most of the caregivers expressed a strong desire to have their children fully vaccinated. However, some of these caregivers had bad experiences at the health facility, including stockouts, long wait times, and poor interactions with health workers. When this happened, they lost confidence in the health system and were no longer willing to spend so much time, effort, and money to continue with vaccination, especially for mothers who were walking 20, 30, even 40 kilometers to get to the health facility. As one mother said, "Sometimes when we arrived at the hospital, they claimed that there were no vaccines, so the child was just weighed. When that happened, I regret the distance I had to travel. The following month, I would not return with fear of spending money and not find the vaccine." The second dropout pattern relates to lack of social support and community perceptions that vaccination is solely the responsibility of the mother. There are many barriers and risks associated with traveling to the health facility, and it's especially challenging for mothers who don't have support from their husbands or other family members. In these communities, social and gender norms place the full burden of vaccination on the mother, and many husbands are unwilling to help, even when the mother is too ill or injured to walk. For instance, this mother said, "The most serious thing is that I can't walk. I have a pain in my leg. When I walk, I feel a lot of pain. When I ask my husband to accompany our child to the hospital, he says that he is not able to take the child on his back. But walking from here to the hospital is complicated with so much pain that I feel." There were also caregivers who dropped out of vaccination because they couldn't find anyone to take care of their other children at home while they went to the health facility. The third dropout pattern related to concern about the side effects of vaccines. Even though most of the caregivers believed that vaccines are important, they had concerns about side effects, namely fever and swelling, that would last for several days after vaccination. This was especially true when children were being vaccinated outside of the normal schedule, after either missing a previously scheduled vaccine or after encountering a stockout at their last visit. When this happened, caregivers perceived that vaccines had accumulated and believed that their child would be receiving too many vaccines at once and would have worse side effects as a result. One mother told us, "What made me abandon it were the side effects of the vaccine. I wanted to protect my son by abandoning the service, and I didn't know that I was harming the child. On the days that the child received the vaccines simultaneously, he would have many fevers, and this happened when he spent many months without vaccinating." The fourth and final dropout pattern that we observed relates to social dynamics between caregivers and health workers. Many of the mothers of partially vaccinated children talked about times when either they or other mothers had been yelled at or humiliated by the health workers. This could happen if the mother forgot to bring her child's vaccination card, if the child wasn't bathed before the visit, or if the mother arrived to the health facility either late in the day or late on the vaccination schedule. Fear of being humiliated in such a public setting drove some mothers to abandon vaccination. This fear also prevented some mothers from advocating for their child's vaccination in instances where the health worker forgot to check the vaccination card or wouldn't vaccinate the child for some other reason. For instance, this mother said, "Many times I went to the hospital. They just sent my daughters to weigh and said they had already completed the vaccinations and didn't even check the children's card. But as a mother, I knew that the last vaccine was missing, and I couldn't question it for fear of being humiliated." Overall, we learned that dropout from vaccination is usually not the result of any single barrier, but instead it's due to multiple different barriers that come together from across the categories of the increasing immunization model. Second, our findings really highlighted the cyclical, iterative nature of the vaccination process. Each vaccination experience influenced the caregiver's decisions to either continue or drop out of the vaccination process, and the balance of facilitators and barriers shifts over time across the vaccination journey. These drivers of dropout are complex and require holistic solutions. My thesis focused only on identifying and describing the drivers of dropout, but I also want to talk a bit about the study as a whole, which also aimed to identify and develop solutions based on the research findings. Following the data analysis, we recently held 2 human-centered design workshops in which we invited the study participants to come together, see the results, and work on identifying solutions that they felt would best address vaccination barriers. We're still processing the outputs from those workshops, but I want to briefly discuss a few recommendations, including some of the solutions that originated in the workshop. Long-term solutions will require health system strengthening, including improved supply chain logistics and cold chain infrastructure, and expanded health workforce to support both fixed facility and routine immunization outreach services. Routine outreach services, which are known as mobile vaccination brigades in Mozambique, were noted by both caregivers and health workers as an important immunization access point that need to be run more reliably and consistently. Finally, community members want to be involved in their local health systems, and respectful and empathetic communication and collaboration by health workers could go a long way to improving vaccination completion. I want to end by thanking everyone who's supported me in this study, including my thesis committee, Donna and Kristen, and all the study team members at Village Reach, especially the 4 caregiver researchers pictured here. I want to also thank Wellcome Trust, who funded this study, and of course a big thank you to all of the participants who contributed their time and their stories to the study. And I will open it up for questions at this point.
Thanks so much, Jocelyn. Nura, do we have any questions?
No, but we have a comment from Deepa, and let's see, Donna has a question. Did the workshop include the health workers?
Yes, so the workshop, including the health workers is a little bit complicated because we also didn't want to be taking them away from the health posts during this challenging time. But we were able to include some of the health workers during the human-centered design workshops.
Great, and Steve has his hand up.
Yeah, very nice presentation and very disturbing presentation for me. My understanding, and I may be wrong in this, but it seemed to me that completeness vaccination numbers in general for Mozambique and even in rural areas used to be higher than that. And my guess is that it may actually be dropping. And this is in the context of, you know, the HIV budget from PEPFAR alone exceeding or being close to the health ministry budget entirely, you know, and the PEPFAR budget goes to, you know, the elites, either the NGOs or the you know, highly paid workers in the health facilities. And you described the problems that the moms identified, you know, in several categories, but 2 or 3 of the 4 categories really focus on the health facility, you know, whether it's the power dynamics or whether it's the stockouts or the treatment of respect or the wait time and all that kind of stuff. And it just makes me wonder, you know, what's happening in the larger picture around health facilities and the fact that, well, we're actually seeing in 2021 a diminution of health facilities in Mozambique at the same time aid is increasing. Is anybody talking about that? And that's number one. And number two, certainly in terms of your findings. And number two, you know, is really the solution to get away from the health facilities and go to brigades, you know, which is simply another way of paying per diems for health workers to go out and get what they're not getting within a kind of dysfunctional, you know, health system where the aren't getting paid enough in their general salaries. Sorry, big question, but a disturbing finding.
So, yeah, I'll start with your first point was about the numbers being or coverage numbers being lower than you expected. That the 50% reported for Zambezia province of vaccination completion is from the 2015 DHS, which is, I think, the most recent reliable data source there is. Official country estimates more recently are a lot higher than that. They claim that around 90 to 95% of districts have reached that 80% vaccination completion target. But the data is very low quality. There are a lot of coverages that are 170% or far above 100%. So, so that's why I'm reporting that initial coverage. But with respect to the vaccination outreach, and I agree with you. This is why I pointed out that I think long-term solutions will require health system strengthening. And that's really strengthening care at the point of service. So including making sure that there are more health workers who are able to deliver immunizations at basically all of the healthcare centers that were engaged in our study, which is eight health facilities. I think that there is only one health worker who was kind of trained in immunization delivery at each of those health facilities. So it's very difficult for them to be managing both the fixed health post as well as run mobile brigades. But I think that it would be interesting to see if Mozambique would ever adopt a similar strategy that Malawi has used, where a lot of their immunizations are delivered in the community by community health workers. Mozambique has a community health workforce, but they're not trained, or their responsibilities don't cover delivering vaccines. And I think that what we've seen in this study is that these logistical issues are a big part of the barriers that prevent caregivers from completing vaccination, just the distance, the time, the money. And I think that a community-centered approach is really important, but it needs to be done in a sustainable way, where these brigades or other outreach services are consistent and reliable, and mothers know that they can complete vaccination just by going to those outreach services.
Last question from Eileen. You may have answered this already, Jocelyn, from Steve, but she asks, compared with earlier literature, did your results shift any pieces of the narrative around reasons for dropout?
So a lot of the work that's been done on studying vaccination dropout has been through more cross-sectional studies and surveys. And there haven't been nearly as many studies that have really looked at it from a qualitative lens. So I think that what our study really kind of brought to light is that these barriers to vaccination aren't acting independently. It's these combinations of barriers. So distance alone does not prevent vaccination, but distance combined with lack of support from family members can be one of these barriers or combinations of barriers that prevent vaccination. So I think that it really highlights that we need a holistic solution that will kind of tackle these barriers from multiple different angles. And yeah, I think that's probably the biggest thing that our findings have contributed.
Great, thank you, Jocelyn.
Thanks so much, Jocelyn. Well, with this, we would finish the first block of today, and we have a break now. So Nura, I see that the next presentation is scheduled by 11:40. What's the plan? Should we reconnect a few minutes before to start at 11:40 sharp?
Exactly. So yeah, please arrive a little bit before 11:40 so we can get started. I am going to leave this little screen up for break. Please mute yourself since we have 1 hour. Mute yourself, put your video off, and we'll see you a little bit before 11:40.
Fantastic. No, thanks and congratulations to all the presenters of this block. We hope to see you still in the next session. So we see you later. Bye. Perfect, Nora. Welcome back, everybody. So let's move on with the next block of presentations. Just as a quick reminder, each presenter will have 10 minutes and 5 minutes for questions and answers. Nora will keep track of time and remind you when your time is due. If you have any questions for participations, please, you can do it through the chat or raise your hand so Nora can give the word after each one of the presentations. So if there are no further comments, we can start this blog with Tikala Itaje to tell us about her thesis work.
Hello, everyone. My name is Tikala Itaje, MPH student with the Department of Global Health. I'm very honored and excited to be presenting my thesis titled Restarting Mass Drug Administration for Neglected Tropical Disease Programs During the COVID-19 Pandemic. My thesis committee members are Donna Dano and Ariana Means. Firstly, here's an overview of the background. Neglected tropical diseases are a group of chronic and disabling diseases most prevalent in settings with inadequate access to sanitation, clean water, and healthcare. Over 1.5 billion people worldwide are affected by NTDs, and Africa carries approximately 40% of this burden. NTDs are typically addressed using mass drug administration, which involves distributing drugs to individuals living in at-risk areas by volunteer health workers called community drug distributors. MDA is the main intervention for NTDs such as lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted helminths, and trachoma. During the COVID-19 pandemic, it has been unsafe for community drug distributors to go into communities to distribute drugs because of the risk of COVID-19 transmission. This resulted in MDA activities being postponed 6 to 12 months due to the World Health Organization guidance on COVID-19 that was released in April 2020. With this postponement, there is an urgency to restart MDA activities to ensure people affected by these diseases are getting the treatment they need. In an effort to understand the context of restarting MDA activities, the Bill and Melinda Gates Foundation and the World Health Organization conducted a study to identify opportunities for restarting MDA programs during the COVID-19 pandemic from the perspective of national government NTD program managers, which are top-level officials in ministries of health responsible in coordinating and overseeing the implementation of NTD activities, and representatives from non-governmental organizations working in the field of NTDs. The specific aims for this study were Aim 1, to identify the challenges of delivering MDA during the COVID-19 pandemic. Aim 2, to identify the solutions for restarting MDA programs. And Aim 3, to describe opportunities to innovate upon restarting MDA activities. This was a convergent mixed method study where the quantitative and qualitative data were analyzed separately and merged to identify key findings. A total of 1,974 NGO representatives working on NTDs in the African region were invited through a listserv to respond to an online survey. NTD program managers from ministries of health representing 48 NTD endemic countries in Africa were also invited by a WHO World Health Organization mailing group to respond to a survey as well as participate in focus group discussions. For the online survey, 10 program managers from 10 countries responded to the survey, giving a participation rate of about 20%. And 37 representatives from 25 NGOs responded to the survey, giving a participation rate of about 2%. And descriptive and inferential analysis were used for the surveys. 3 focus group discussions were conducted, one each in English, French, and Portuguese. 36 program managers from 17 countries participated in the focus group discussion corresponding to their language preference, and the country level response rate was about 35%. And thematic analysis was used for the focus group discussion transcripts. I would like to acknowledge my positionality. Although I'm from a low-income country, Malawi, which has a high burden of NTDs, I did not participate in the data collection. I only conducted a secondary data analysis. Moving on to the results. This slide shows the results for Aim 1, challenges to MDA delivery among program managers. As you can see from this graph, about 60% of program managers reported challenges in planning activities during the pandemic. About 50% of the program managers also reported challenges in conducting trainings, adhering to COVID-19 preventative measures, as well as funding challenges. In the focus group discussions, one program manager had further elaborated on these challenges by stating that even if we have to launch MDAs now, there needs to be a basic level of safety, and the logistics of this generate extra costs compared to what was previously planned.
5 minutes.
Moving on to challenges to MDA program delivery among NGO representatives. In this graph, you can see that about 65% of NGO participants reported challenges in funding. it was noted that funding was being diverted to the COVID-19 response and interventions. Additionally, about 51% of NGO participants reported another challenge in workload, staffing, and program costs. The other main challenge commonly reported about 45% of NGO participants is community engagement, which was also brought up by program managers. Program managers did express their concerns in the focus group discussion about community members fearing getting COVID during MDA activities. One program manager stated, "In the midst of COVID, many communities are afraid that health workers are the ones carrying the disease into their communities." Moving on to the results for AIM-2. Here you find that participants reported modifying drug distribution strategies as one of the solutions for restarting MDA. Firstly, MDA activities are often done by having large community gatherings in one central place, in schools or marketplaces, where there would be long queues to distribute the drugs and physical distancing may not be possible. Participants therefore suggested modifying drug distribution methods to incorporate COVID safety precautions by delivering drugs door-to-door or via fixed point delivery at health centers as a way to mitigate risk of transmission. Further, program managers in the focus group discussion proposed prioritizing the use of spoons as well as pre-measured envelopes containing drugs to minimize community drug distributors' contact with the drugs. Secondly, with communities fearing about getting COVID, participants suggested adopting community sensitization messages that respond to the specific concerns and fears. For example, community sensitization methods could be modified to emphasize approaches that avoid large gatherings, such as public address systems mounted on vehicles to deliver information to communities, like the picture here. Moving on to the results for AIM-3. Firstly, program managers and NGO participants reported plans to make use of mobile technology to collect data. Usually, MDA programs use paper-based data collection and door-to-door visits to collect household data, which takes more time, and there are many opportunities for data errors. Now, program managers suggested in the focus group discussion the use of mobile data for data collection to minimize the risk of COVID-19 transmission, but also an opportunity to collect data rapidly and improve upon NTD monitoring and evaluation.
2 minutes.
Secondly, participants reported plans to use online platforms for training health workers and conducting meetings. This would reduce travel during the pandemic, but also make in-service trainings that were done before more accessible without the need to travel to specific locations. Lastly, program managers suggested integrating NTD program activities with other health programs. Integration here is considered in the wider sense, such as coordination of program activities among different disease-specific programs. Program managers suggested integrating with non-NTD programs such as COVID-19 control as an innovative opportunity because MDA programs can reach the most rural areas, and there's potential to leverage MDA using door-to-door delivery for COVID vaccine distribution, for example. Limitations. It has been 8 months since the data was collected, and the situation in these countries may have changed over time. And there was a small sample size, so the results may not be generalizable. In conclusion, and in summary, the study identified challenges to implementing MDA during the pandemic, solicited ideas and innovations for how to safely restart MDA using strategies such as mobile data collection and program integration that could help pool limited resources together. I would like to acknowledge the Ministry of Health, NTD program managers, and NGO representatives that contributed to the findings, the Bill Melinda Gates Foundation, and the World Health Organization, but most importantly, my thesis committee members that have supported and guided me through this process. Thank you.
Thanks so much, Tikala. Great presentation. Nura, do we have any questions?
No questions yet.
Tikala, while some questions come out, one that I have is, what do you think is like the main factor that was like the main challenge posed by this COVID situation that the programs had to address?
I would definitely say from both the program managers and the NGO participants, you find that funding was a big challenge, especially during the COVID pandemic. You know, governments were going through this situation where a lot of funding and resources were going to respond to the COVID intervention. So I would say the biggest challenge and disruption was around just not having sufficient funding and resources to implement MDA activities for NTDs.
Great.
Great. We have a question from Ariana, who's got her hand up. Please go ahead.
Thanks. I think my question might be similar to Steve's. I was wondering how the NGO and program manager perspectives differed, if they did at all, and like, why do you think they differed?
Good question, Ariana. There wasn't any a great difference between the response from NGOs and program managers, but you can see that just giving the example of how NGO participants, let me just go back to that slide. Here, where you can see that, you know, among NGO representatives, they had reported the biggest challenges around funding. But, you know, you can see this because NGOs depend on funding so much to implement their activities. And with MDA's, mass drug administration, being postponed, a lot of the donors went dispersing their grants or funding to most of these NGO representatives. So you would find that they would report funding as the biggest challenge because of that. And with the program managers here, you found that, you know, they had reported planning as the biggest disruption they experienced. And you can find that, you know, with the Ministry of Health, where program managers are working within a bureaucratic institution, planning activities is always a key thing they do within an administrative body like the government. So I do feel like program managers would have reported planning as their biggest challenge because of the institution that they operate in.
All right, so you've got a couple questions. So one from Eileen. Did you get a sense of how common, it was to pause or skip around or more of MDA? Or did MDA continue in some places with additional complications due to COVID?
So one of the survey questions that was asked, let me just go down to that slide, were around plans to restart or asking, you know, most of the participants if they had started any mass drug administration within their countries. And you can see from this table that some participants did report starting MDAs during the time of when the pandemic was at its peak and during the time of the postponement when the WHO guidance was released. And with that, just looking at this table, you can see it's a really low percentage of the number of participants that reported starting MD activities during the pandemic, which could also show that they had been challenges that they were experiencing, which were mostly shared in one of my slides, where you're saying that, you know, you're trying to conduct MDA, but, you know, there's community fears within the communities. There's also issues of community drug distributors that have to go out and distribute these drugs, where there's also an issue that was reported saying that, you know, most of these community drug distributors needed an incentive to go out and distribute drugs in the midst of a pandemic. So they were definitely challenges that were reported for those that had reported that they had started MDA activities.
Okay, great. So there's great questions. So I'm going to read the one from Claire. Claire says, now that the pandemic is winding down, with the global distribution of vaccines, how do you think this will impact how NTD program managers deliver MDA in the coming months and years? Do you think trust in health systems around the vaccines will impact the delivery of MDA? In 20 seconds.
Thanks, Claire, and good question. So I do believe that there is an opportunity for program integration, and this year in January, World Health Organization launched their roadmap for NTDs, and one of the key objectives is around program integration. So I do believe that if the NTD program can integrate with what's being done around COVID, there could be an opportunity where, you know, resources are brought together. And I brought up that example saying that, you know, as community drug distributors go out into deliver drugs at a door-to-door, they can find a way of also using that opportunity to distribute COVID-19 vaccines. So there is opportunities of alignment, and I'm hoping that, you know, countries can seize that opportunity and take up program integration as an option of and as an opportunity for innovation.
Great, thank you so much. So you still have a couple more questions, if you don't mind just responding to them in the chat box so that we can see the responses as well. Thank you, Tikala.
All right, thank you.
Thanks so much, Tikala. Great presentation. And let's move on then to the next one. It's by Miranda Benson. Miranda, if you want to share your screen.
Hello. All right. Does this look okay to everyone?
Good. Good.
All right. Hello, welcome and thank you for coming. This is my MPH thesis presentation for my thesis work to date on gender-based violence in Timor-Leste, knowledge, attitudes, and behavior of community leaders. So just a quick outline, we'll talk about background, the overall Harmonia activity, which my thesis sits under, the thesis aims, methods, my positionality, preliminary data, and next steps. And for some geographical background, here is the position of Timor-Leste on the globe between Indonesia and Australia, and I'll be talking specifically to two municipalities, Lakisa and Amera. So for background, violence against East Timorese women is widespread and understudied. We believe drivers of this violence are a culture of gender inequality and discrimination driven by societal patriarchal traditions and a long history of armed conflict, most recently with Indonesia that ended in 1999, which leads to an extremely high percentage of women experiencing violence by an intimate male partner in their lifetime, up to almost 60%, with 47% reporting violence in the last 12 months. This project is particularly important because there has been no dedicated research at this level, the village level, about the prevalence, health consequences, or risk factors of violence against women. So the overall Harmonia activity is a grant project done by University of Washington's Health Alliance International. It includes 2 interventions that will take place in 31 villages spread across those 2 municipalities. It is focused on 2 different challenges. The first has to do with the social context around gender-based violence, where it is kind of just tacitly accepted. And the second is that health providers, part of this social background is that health providers lack training to recognize and to respond to gender-based violence. So the interventions map onto there. The first is community microplanning, which will be monthly workshops to bring together community leaders to discuss and develop locally relevant solutions to gender-based violence. And the second is training for health providers, so learning labs for health providers regarding the ability to notice and respond properly to issues of gender-based violence. My thesis pertains to the first, this micro. So my thesis aims are to assess personal knowledge, attitudes, and helping behaviors related to gender equality and gender-based violence among community leaders in 31 villages who will participate in HAI's community microplanning intervention in these 2 municipalities. The participants for my thesis and for the microplanning intervention, strong youth representation, strong female representation, and inclusion of LGBTI people and people with disabilities where possible. And I'm happy to say that we were able to do quite well on these participant goals. We have nearly 98% of our participants are community leaders. The mean age is 41 with a standard deviation of 10. The youngest participant being 22. So we didn't get all the way down to the legal age of 17, but we got pretty close. 39% of the participants are female. And as expected, the inclusion of LGBTI and people with disabilities was something difficult to find. So we found less than 1% around this inclusion criteria. So in terms of gender specialist out of La Trobe University, to develop a survey, which we compared later with an online survey, Timor-Leste demographic survey and WHO surveys around gender-based violence. The questions were largely binary, so yes, no, not sure, and Likert scale, varying between strongly agree and strongly disagree. We had some open answer questions so that participants could add extra detail if necessary. The surveys were developed in English, and then they were translated, field tested, and administered by HII Timor-Leste team, which is a permanent team in Timor-Leste. And for analysis, using RedCap, excuse me, sorry, it was administered using the RedCap mobile app. And this made the process very easy for analysis since I could extract the data without the need of assistance translating. However, for the open answer questions, those are still in translation, so they will be used later by the Harmonia team.
5 minutes.
So important to speak to my positionality. I don't share many of the intersecting identities of the study population. I'm not Timorese, though I am a woman, and our participant group represents a wide variety of experiences. So for example, we have a wide range of education levels. But importantly, discussed the language of the survey before, but I wanted to reiterate that here. And now I'd like to show a little bit of the preliminary data. Before I do so, I just call it our disaggregated data, but pertaining to that are answering
Miranda,
their education level are also going to be the same people that are answering. Oh no.
It's fine. How about you try stopping your video, just your
Okay.
video? Yeah.
All right.
Yeah, okay.
Is that working a little bit better?
It tends to, but go ahead, continue, sorry.
All right, so yes, all I'm saying here is that we have overlapping data buckets here. So my first example is for our bucket of knowledge, and let's see it. I should have said this before, but the survey had different kind of ideological buckets that we were asking about. One is knowledge, another is attitudes, helping behaviors, and community support. So here's an example of an answer to a question about knowledge, which is only the victim is able to report domestic violence to the police. We can see here that there is some disinformation around whether or not this is true. And we can see that the answers kind of follow what we might expect according to education. Here's an example about attitudes. It is natural, God intended that men should be the head of the family. I found this one particularly interesting because for most of the questions, we didn't see many people giving the answer strongly agree in the direction that we weren't expecting. Here's an example for community support. And I know it's a little hard to see the different lines here, but my big takeaway from this one that was kind of exciting is that we see a big overlap. So people feel quite similarly regardless of their socioeconomic or gender background. And what is particularly exciting for me is that there's a lot of acronyms down here. But in summary, where we see big spikes in knowledge about organizations, they tend to be most local. So that to me tells about the importance of the Harmonia activity overall, since it is very community-centered. Here's another example for helping behavior. You should verify how accurate a woman's story is by asking the alleged abuser or the woman's friends and family. And I do want to point out that there are many questions where our participants had very strong knowledge, and I'm pulling these out in particular because they'll be talked about in my discussion section for room to improve. So next steps are to develop key findings and implications. I'll create scales to assess items of similar constructs. So again, these ideas of knowledge, attitudes, behaviors. Developing that into the discussion section, which will include implications for the continuing Harmonia activity meetings. So that in the community microplanning sessions, we can speak to particular topics that might need extra training or brainstorming. And then we'll share the findings out to both the Seattle and Timor-Leste HAI teams, the community microplanning participants themselves, and the United States Agency for International Development, or USAID. And I would like to acknowledge Marianne Mercer, my chair, and Jennifer Beloza and Susan Thompson in my committee, and Kaylee Wild, our gender specialist, and the HAI Timor-Leste team. Thank you very much.
Thanks so much, Miranda. Very nice work. It seems, Nura, that we have some questions in the chat.
Yes, we have one from Marianne who says, Miranda, did you have any particularly surprising findings?
I wouldn't say I had anything that was terribly surprising. It was interesting, and I'm excited to make these scales across my video. Again, it looks like my internet's not working too well. But within these categories, there's a pretty wide range of understanding. So in knowledge, we had, about half of the questions where 90% of the participants gave the answer that we were expecting, or that we are, hoping they would give. And then there are others where it essentially flips. So it'll be interesting to look into more reasons about, why we see those differences within the same kind of construct.
All right, then there's another one from Deepa who says,
hello everyone, Lydia Sosifo Linda Umutone.
I'm sorry, do you mind putting yourself on mute for a bit? Thank you. So question from Deepa who says, lovely presentation. I wonder what are your next steps from here? Might you describe what your plans are for future connections with the community on these results?
Yes, so this is something that I'm really excited about. So currently, the Harmonia activity is doing these community microplanning workshops in 1/3 of the villages, and we'll add another third each coming year. So that gives us a lot of time to send back the data so they can integrate them into their workshops. And as I'm graduating, I won't be personally involved in this, but I'm really hoping that the data that we give can inform the work that they do.
Great. We still have time for a couple more questions. Any questions for Miranda?
Miranda, you show some examples of questions, some related to knowledge, attitudes, but overall, did you find more differences in the ones related to knowledge or attitudes, let's say by educational status, or pretty much the same?
I would say there was quite a bit of difference regarding educational status, and it wasn't always intuitive, which will be interesting to look at. There are some cases where participants with primary education or less gave a far higher percentage of correct answers than those with middle school education. And there were some examples where participants with university education surprisingly gave a higher percentage of an incorrect answer than those with lower education. So it'll be interesting to see like to hypothesize about why that happened. I'm kind of wondering just off the cuff if greater knowledge about certain topics can introduce more ambiguity. But overall, there wasn't a ton of variation. It kind of seemed that if the overall community felt strongly about a certain question, that most people were in kind of a similar range.
And Miranda, I'm going to batch these two questions together. One is from Susan Thompson and one is from your peer, Isabella. So Susan says, Miranda, one of the issues that comes up in data from Timor-Leste is an acceptability of violence against women. What did you find in your data regarding the acceptability of violence against women? Isabella says, do you know how COVID may have impacted violence against women?
Thank you for those. So regarding acceptability of violence against women, what I found has stood out to me to be most interesting is that when we're looking at kind of soft drivers, or I guess soft violence, as I would say it, so kind of more verbal or economic abuse, excuse me, not economic abuse, verbal or emotional abuse, it seems that participants had a much more confident grasp on the like unacceptability of that type of activity. Whereas in terms of physical violence and sexual violence, there seemed to be a lot more confusion around when that is appropriate, which is never. In terms of COVID, you know how COVID has impacted violence against women, or we can hypothesize how it has in Western countries, given that women are often, you know, stuck more often in their homes. And I would hypothesize that that may be an issue around the globe. However, COVID in Timor-Leste was luckily very mild up until recently, and the data was collected in February. So my heart goes out to the East Timorese right now, but it was not really a big problem when the data was collected.
Thank you.
Okay, no, I think we are on time, Nura, for this presentation. So thanks so much. It has been a fantastic work, Miranda. Congratulations. And,
Thank you so
we
much.
we gotta move on to the next presentation by Linda Sawanwida. Please, Linda, if you can share your screen.
Yes, thank you. Okay, hold on. Sorry. Let me stop share. Okay, can you see my screen?
Yes, yes, we see.
Great. Thank you for joining. I'm quite nervous, but thank you for joining. My name is Linda Tawamnita, and I will be presenting my thesis, which is an evaluation of Rwanda's COVID-19 response from the perspectives of decision makers and frontliners. Steve Gloyd is my thesis chair and Jeff Lane is my committee member. In terms of positionality, I am a Rwandan citizen. I'm bilingual, so I speak Kinyarwanda and English. I'm also a UW graduate student, and I've interned and worked with Rwanda Biomedical Center in the COVID-19 response. In terms of COVID background, I think most of you are aware of a lot of this, but this pandemic has had an enormous toll on the world, not just in terms of health outcomes, but also socially and economically and other aspects. And as of May 25th, globally, there were 167 million cases, 3.4 million deaths, and 1.4 billion vaccines administered. And these are really large numbers that might be hard to imagine, but within the continent of Africa, there are 4.7 million cases, a little over 129,000 deaths, and only 28.8 million vaccines administered. And when looking at Rwanda, there's 26,700 cases, 349 deaths, and according to Rwanda Biomedical Center, there have been 350,400 vaccines administered. And this pandemic, of course, still requires an effective and ongoing public health response. So the study aim is to first describe Rwanda's COVID-19 preparedness and response policies, as well as identify the specific public health measures that were implemented and understand the strengths, gaps, and lessons from the response policies and interventions. In terms of methodology, I conducted a systematic literature review to describe these policies and guidelines using existing articles, peer-reviewed articles, gray literature, as well as national preparedness response plans and other documents. In addition, I also conducted 8 semi-structured interviews with the professionals involved in the different sectors of the pandemic response. These took between 30 to 60 minutes. Data analysis, I used the rapid and rigorous qualitative data analysis for the interviews, and these key informant interviews were recorded and transcribed, and these transcriptions were then organized, reduced, and analyzed into the key themes and quotes, some of which you will see today. Just briefly, before I forget, I just wanted to share also the people that I interviewed. This is a list. We can go back to it in depth if you're interested in the people I interviewed. In terms of preliminary results, so some of the themes from the key informant interviews, one of them was comprehensive planning and coordination. Another was response intervention, looking at surveillance and laboratory activities, non-pharmaceutical public health measures, as well as the COVID-19 vaccine rollout. And the third theme was public awareness and community engagement. And I'm going to pass through all these briefly. In terms of coordination and planning, so structures were set up to manage the pandemic through by developing policies and implementing actions and strategies. And in addition to that, they were also set up to create and implement the national preparedness and response plans. And in addition to that, this was very much a multi-sectoral coordinated involvement. So the health sector could not have responded to this alone. We saw that there were different actors, partners and ministries and youth that were involved in this. And a quote from somebody while talking about the multi-sectoral involvement, they said, from the different teams, people, organizations, institutions, all doing things that may not necessarily align with your plans. But the good thing is, at the end of the day, the top leadership made it clear that we go by the science, we follow what Minasante, which is Ministry of Health, and RBC are advising. In addition to that, it was a very much decentralized response. So initially it was heavily, the response was heavily dependent on the city of Kigali, but after some time, other provinces and districts were also included in the response. When looking at the response intervention, there was, due to the transmittability of COVID-19 and the presence of, variants, it was crucial and still is crucial to have high screening and testing capacity. So there were different mass testing activities through random drive-throughs, as well as testing high-risk groups and travelers, among other groups. In addition to that, it also required the enhancement of lab testing capacity. So something that was initiated was a pooling strategy whereby COVID-19 PCR test samples were batched together in a group of maybe 10 to 20 samples and then tested in one pool. And this approach increased the number of individuals being tested using the same amount of resources. In addition, there was also non-pharmaceutical public health measures, as we've seen in other places, social distancing measures, curfews, national and regional lockdowns. And to respond to the COVID cases, there was in case management, the creation of isolation centers. And during the national lockdown, a couple of health centers and some hotels and boarding schools were repurposed into isolation centers for COVID-19, for severe COVID-19 patients. In addition, there will have also been the implementation of home-based care for mild and asymptomatic cases. Another intervention has been the COVID vaccination uptake. So the vaccine task force was initiated for the preparation and distribution of the vaccines that had been obtained through COVAX facility, and priority groups have been identified and are being vaccinated. One asked about some of the challenges with this, this vaccine preparation and distribution. One of the participants mentioned, as an African right now, I would like to see more justice and equity and fairness in having access to vaccines. There were some challenges in implementing these measures, one of them being just balancing the efforts to minimize the spread of disease while also ensuring that the economy is going on and people's livelihoods are not negatively impacted. Somebody said, because we need to survive, we need people to coming in with essential supplies, food, whatever business, but also we need to avoid the spread of disease. So it's this sort of challenge of balancing the minimization of the spread while also ensuring that other aspects of people's lives continue.
2 minutes.
Thank you. So the last theme is public awareness and community engagement. So the risk communication and community engagement team was created to enhance this public awareness as well as use mass media campaigns and social media. And one of the benefits of this, one of the strengths of this was establishing trust through consistent communication as well as feedback. I will end with the lessons learned. The first one is the importance of having a proactive and multi-sectoral people-centered leadership. This is to create trust between government at all levels and people, as well as having a harmonized coordination between the different sectors, partners, as well as on a regional and international level. The second is continuing to strengthen the health system as COVID has tested and tried the system to be more, hopefully be more resilient, and continuing to improve access to preventative health services, even in times of pandemics, and reducing financial barriers. As the third lesson is investing in and managing human resources with global lockdowns and travel restrictions, especially with last year. In a sense, it forced Rwanda to look inwards and mobilize local expertise and human resources. And somebody said a pandemic can occur at any time, because at one point we needed a lot of epidemiologists, a lot of statisticians, a lot of IT special experts. You can't create those in expertise in one morning. So this goes to the point of creating or enhancing human resources. And the last one is investing in research and technology. Health information systems were used for faster and more comprehensive information, comprehensive management of information, as well as continuing to digitalize healthcare in cases where people can't go in person. Thank you very much. I would like to acknowledge my thesis chair, the study committee, the study participants, friends and family, Rwanda Biomedical Center, and the Department of Global Health. Thank you.
Thanks so much, Linda. Very interesting work. Congratulations. Nura, do we have any questions?
Good job, Linda girl. Let's see. Yeah, question from Steve. So Steve says, can you describe what COVID work you personally did in Rwanda, including reflections on your own achievements and challenges?
Okay, thank you. So I had initially volunteered my time with Rwanda Biomedical Center, and part of that I participated in like the epidemiological surveillance team, so conducting or participating in the random drive-thrus to test people in different parts of Kigali, as well as the transit hotels. In addition, I had also briefly participated in the national strategic preparedness plans for the second national preparedness plan. So drafting up the second national preparedness plan. So a little bit of that as well. So just a bit of epidemiological surveillance as well as strategic work.
Awesome. Question from Ariana, who says, thank you for such an excellent presentation, Linda. This is a very important piece of work. The radar technique is still relatively novel. What were some of the advantages and challenges of applying this qualitative analysis technique to your thesis?
Thank you, Ariana. I think one of the sort of challenges was that, yes, it's new, and I, in a way, had to teach myself how to use it. And I think that it's a very effective or efficient way of getting what the key themes and the important quotes are when you don't have necessarily all the time in the world to go through an in-depth qualitative data technique. And I think it's also probably beneficial for people who are beginning to get into the qualitative data analysis. So I think for me, it was learning how to use it myself. And yeah.
Great. Question from Deepa, who says, Linda, amazing project and presentation. So proud to see this in completion. Can you talk more about what your data tells us about what we need to do now to prompt the international audience and vaccine makers about the fact that we are in an unprecedented time and need for waivers for increased vaccines for limited resource settings?
Yes, thank you, Deepa, for that question. I'll try my best to speak on it, but I think based on what I've read and the interviews, Rwanda in particular is very much ready and interested in vaccinating its population. But it just comes down to the limit of, can we, not just as Rwandans, but, mainly Africans and others, can we also get access to these vaccines? So it's not just an issue of not, wanting them. It's an issue of having fair and just access to these vaccines. So I don't know if I can answer that. I don't know if I've answered that well, but the need is there. And I think on my first slide, and this is something that took me aback, was looking at the number of vaccines that have been administered globally, and then looking at what the portion which has been vaccinated within the continent of Africa, and then even going through that smaller portion in Rwanda. It's a bit heartbreaking. So
great.
Yeah, I don't know if I answered that question.
And in a couple words, if you can answer this from Floyd, who asks, what do you think the United States can learn from what Rwanda was and is accomplishing?
Okay, that's a loaded question. I think in terms of leadership, having a leadership that involves the communities and is proactive, that's one way, but I know that can get very political, so I'll just put it that way. As well as the willingness to work with people and to work with different stakeholders and community members. And I don't know if it's ministries in Rwanda, maybe departments here, and having it not so much be just sort of siloed and have it be the CDC, but reaching out to different stakeholders that will definitely help in terms of whatever you're trying to work on in terms of public health.
Wonderful. Thank you, Linda.
Thank you. I hope I answered that well.
think he did.
Thanks so much, Linda. This was a fantastic presentation. And well, now with this, let's move on to the final presentation of this session with Eileen Kasura. Eileen, if you want to share your screen.
Great. Let's see. How does that look? Good?
Perfect.
Yeah, and perfect. And in true 2020, 2021 fashion, I do have some tree work going on next door. So I'll leave that up to you, Nora, to tell me if that becomes very distracting, but I'm hopeful we'll be okay. So my name is Eileen Kasura, and today I'm going to present about my thesis work on identifying opportunities for optimizing mass drug administration for soil transmitted helminths in the context of the Deworm-3 trial. Soil transmitted helminths, or STHs, are a group of parasitic intestinal worms which are transmitted through contact with infested soil. In places without adequate sanitation infrastructure, they're quite common. And the Global Burden of Disease study estimates that they lead to over 2 million DALYs annually, primarily in young children. Infections can lead to malnutrition and cognitive and physical impairments. The WHO recommends annual or biannual reach 75% coverage. Mass drug administration, or MDA, are some of the largest community-based primary healthcare campaigns in the world, reaching over 1 billion people each year for STHs and similar diseases. High coverage MDA reduces morbidity in the highest risk population, but there remains a reservoir of parasites. This means that people get reinfected and treatment will ostensibly need to continue in order to keep morbidity in check. Deworm-3 is a cluster randomized trial that is testing whether treating the entire community with deworming drugs can reduce the reservoir of parasites enough to interrupt transmission. Deworm-3 is also interested in how community-wide campaigns are implemented to quickly translate study findings into programmatic action. In-depth process mapping was used to understand the flow of activities needed to implement high coverage MDA in 18 participating clusters. Process mapping is a system science tool used to itemize and visualize the steps involved in a process. 3 aims guided my analysis. Aim 1 addresses the plans made at baseline. Aim 2 is about describing how MDA implementation was adapted over time. And aim 3 is about describing fidelity to planned activities over the course of the trial. Process map data was collected 4 times. At baseline, participating clusters held multi-day workshops. At these workshops, they came up with all of the needed activities to achieve high coverage MDA. For each activity, they stipulated the type of activity and the target goal and timeline. So for example, if the activity was to train community drug distributors, the goals might be that 100% of drug distributors are trained and timeline 2 weeks prior to MDA, for example. At this workshop, groups also put these activities onto a literal map on the wall to draw out the process or flow of activities. You can see pictured in the photo at the bottom. Update data was then collected annually for 3 years. At these updates, progress towards the goal and timeline for each activity was noted. If there was a deviation from plans, a reason was given. In addition, activities could be removed or added at each update, excuse me. And finally, though my full analysis includes data from all 3 sites, today I'm presenting only data from Benin and India, as we're still awaiting the most recent data from Malawi. I produced descriptive statistics for baseline plans, adaptations, and fidelity to plans. Because data was collected at this cluster level, this enabled comparison by a number of factors, which are listed here on the slide. And then I also used the R-package diagrammer to visualize each of the maps. Before diving into results, I'll share a couple of items about my positionality. I personally do not have direct experience implementing MDA in any context, and I performed data analysis remotely from Seattle. Additionally, the Benin data was translated from Beninese French, and I do not speak French, so I was unable to confirm these translations. Next, I'll share a selection of the results from this analysis. This table contains some information about baseline plans, and already we're seeing some interesting comparisons. For instance, we can see that Benin and India have pretty different number of average activities, and in fact, their ranges are mutually exclusive. This makes sense as clusters are much larger geographically and more rural in India, while clusters in Benin are in a peri-urban area. We might expect that implementing door-to-door MDA in a more dispersed area takes more activities to achieve high coverage. We also see that clusters that implemented community-wide MDA indicated more activities than those that implemented school-based MDA. Again, this is rather intuitive, as we might expect that door-to-door delivery results in more activities than fixed point delivery at schools. We can also take a bit of a deeper dive and look at the distribution of activities between the 7 activity types that we offered as choices. Here, we get a sense for the differences between MDA, in this case, between Benin in gold and India in purple. In India, over half of planned activities are either in these planning or drug supply chain activity type categories. While we can see that in Benin, there is more of an equal spread of activities between drug supply chain, training, community sensitization, and actual MDA delivery.
5 minutes.
India achieved higher coverage than Benin across the length of the trial, so we might hypothesize that the focus on planning in India contributed to that higher coverage. Moving to aim 2, we can look at changes to the MDA process over the course of the trial by when the activity is meant to occur. The time categories on the left are assigned to each activity based on when it's meant to occur. This can give us a sense of not only when most activities occur in relation to MDA, but also timeframes that are commonly subject to adaptation. Here, we can see a net decrease in the number of activities which occur very early before MDA. This net decrease takes place at update 1, which makes sense as this was really the first opportunity to add or remove activities from this data set. Conversely, though, activities that take place directly before or during MDA had small yet sustained net growth over the 3 update rounds. The time period just prior to MDA had the activities both added and removed. Together, this suggests a shifting of activity from far before MDA in the planning stages to just before and during MDA over the course of the trial. This chart shows the proportion of total activities in India, just India alone, with deviation attributable to one of 8 reasons seen at the bottom. These categories include purposeful changes, which are in light and dark green, and other reasons such as resource constraints or community influences. If you recall, we have 2 kinds of targets, and deviations from goal targets are on the left and time targets on the right. Most applicable to time deviations. I'll also note at this point that deviations are not directional, meaning that time deviations are counted both when an activity happens later than planned and earlier than planned. This chart shows that there were more time than goal deviations at every round, and that sizable amount of deviations are for purposeful reasons. COVID, which is in light blue, is obviously important for round 3. But aside from this, reasons such as community influences or resource constraints were responsible for only a limited proportion of activities with deviations. And finally, visualizing these maps is a tool for understanding efficiencies and inefficiencies in delivery. This is an example of a map from a cluster in Benin. We can see the clustering of activities by type, which are the color coding relates to the type of activity, according to when the activity takes place, such as, for instance, most or all of these drug supply chain yellow activities in the 2 weeks leading up to MDA. And this can help us identify potential adaptations or changes to process that might avoid dependency delays related to those activities. We can also see gaps that added activities fill, such as these 2 outlined in bold, community sensitization activities, and also identify activities which are crucial for later ones, and again, use this information to identify potential bottlenecks and avoid dependency delays. Compared with the typical MDA cascade that's produced by the WHO, these process maps generate a lot of rich contextual information about how MDA is implemented. And here I have a couple of key messages based on all of this analysis. The analysis of baseline maps and differences between sites indicate that there's a number of different viable ways to implement MDA. Each cluster has its own mix of activities, but we do see real differences in the number and spread across activity types between Benin and India, for example. That said, what constitutes an activity is likely different across settings, and some singular activities in one cluster might be broken down into multiple activities in another cluster. This is a limitation of this analysis, which I explore further in my thesis. This analysis also suggests that adaptation is an ongoing process. From planning stages to later rounds of MDA, we can see a shifting of activities which occur far before MDA to ones that occur just before and during MDA. It makes sense that a lot of this shifting happened at the first update, which was that first opportunity, but we do see this iterative process continued on through later rounds as well. From the analysis of deviation reasons, we also see that many deviations are due to purposeful changes, even during an event like COVID-19. This suggests further that each successive round of MDA is an opportunity for adaptation and refinement of plans, and that MDA is not one size fits all. Optimizing delivery of deworming drugs for high coverage will need to include contextual factors such as are explored in this analysis. To this end, process mapping itself holds promise as a way to help teams articulate a shared vision of tasks and record and study changes to their plans over the course of successive rounds of mass drug administration. Many thanks to Deworm3 team for support on this project, and I would like to especially thank Ariana Means, Chloe Morozoff, and Claire Guay-Chore for their support. And with that, I'll take your questions.
Thanks so much. Eileen, we have some time for comments and questions. Nura.
Yes, so, okay, one from Isabella, who says, can you explain more about historical coverage and any patterns you see regarding it?
Yeah, great. I'll just go back. So historical coverage, just briefly, each cluster that participated in process mapping was assigned either historically low or high coverage. You can see here at the bottom. And that meant that was assigned based on like previous MDA campaigns for either lymphatic filariasis or trachoma. And so, and then we could compare between clusters that previously had low coverage and previously had high coverage. And we might expect that clusters with low coverage might have fewer activities, for instance, or they might have a less of an emphasis on planning potentially. That might be a hypothesis. But really, as is seen here on this slide, and endures through other analyses that I don't have time to show today through adaptations and deviations, there's really not much of a difference observed between low and high coverage clusters. And so I think that is one kind of interesting finding that might point to the fact that lower previous coverage might not be such a large indicator of future high coverage MDA. So thanks.
Awesome. One question from Steve, who says, very nice presentation. To what extent are MDAs dependent on INGOs and donors, especially in BINA? How might national institutions be able to maintain or expand MDA, especially the community-based activities?
Yeah, I think that's a really good question, Steve. And you know, this analysis took place in a cluster randomized trial setting, and I do know that NGOs have been involved to varying degrees, and it differs by country. So between Benin and India and Malawi, certainly it differs. But I don't know the extent to which NGOs are primarily, I know in this case, in Malawi, most of the activities are undertaken by, or the MDA delivery activities anyways, are undertaken by an NGO. But of course, there needs to be coordination between government, who is doing a lot of the drug supply chain activities, and NGOs who may be in fact delivering the drugs door to door, for instance.
Great response. And the last one is from your chair, Judd, who asks and says, great job, Eileen. How do you envision that national guidelines or WHO guidelines can incorporate the idea of adaptive responsiveness over time, as opposed to a fixed directive of what activities should be completed when?
Yeah, I think I'll just maybe share this slide. I think that this is part of the power of this process mapping activity, which allows for a lot more information to be gleaned about not just what's planned, but what actually happens on the ground. And so I think, I think that taking a step back and looking at the kind of adaptations that are made and suggesting potential themes in the types of adaptations that are made along the way may go a long way to providing some flexibility and opportunities to, like, prompts to contextualize plans when they're even in materials that are produced by an entity like the WHO. I think that this offers a lot of additional insight that could be used in those sorts of plans.
Very good. Any other questions, Nura?
That's it.
Great, thank you.
Okay, no, well, with this, congratulations, Eileen, great work. And with this, we get to the end of today's presentation. I think the quality of the work is really impressive. Steve commented it yesterday, but the same impression holds for today, that really all these are high quality works. We look forward to see the final thesis and encourage you to move on to publication or results, because really these are great works. So, and in very important contributions. So I would like to thank everybody for attending, especially the relatives, friends, presenters, the faculty that is also joining us, and also extend you the invite for tomorrow at 9:30. We're going to have another session like this. And well, I don't know, Steve, Nura, if there is any final comment or housekeeping information that we need before we adjourn.
No, great job, everyone. Today was great. As Bernardo said, we have presentations tomorrow moderated by Deepa. We have 14 presentations, and I really hope you all are able to attend as many as you can. And yeah, thank you so much. Steve, anything to say?
Thumbs up. Great job, guys.
Great.
Everybody.
Okay. Have a good afternoon, everybody. See you.
Bye.
Bye.